You are most welcome to this talk. Now, today I want to walk through some data that has generated considerable discussion over the past few years, and that is the prescribing patterns of midazolam during the early stages of the pandemic in the United Kingdom, and what the available evidence does and does not tell us about outcomes associated with this medication. This is a topic where emotions can run high, and I think it is therefore particularly important that we approach this with care, looking at what the numbers actually show, understanding the context, acknowledging the limitations of the data, and being honest about what remains uncertain. Now, before we begin, I want to be very clear about what this video is and what it is not. This is an educational discussion of publicly available data and published analyses. This is not medical advice. I am not making accusations against any individual, institution or government. I am not claiming to know with certainty what happened in every care home or hospital during those extraordinary weeks in the spring of 2020. What I am doing is walking through the evidence as it exists, explaining how to read it and highlighting where the gaps in our knowledge remain. If you have concerns about medication use or end-of-life care, please speak with a qualified healthcare professional who knows your individual circumstances. Let me start by explaining what midazolam actually is, because I think this context is essential. Midazolam is a benzodiazepine medication. It belongs to the same family as diazepam, which many of you will know by the brand name Valium, and lorazepam, which is Ativan. Benzodiazepines work by enhancing the effect of a neurotransmitter called gamma-aminobutyric acid, or as we call it in the clinical world, GABA. This produces sedative, anxiolytic, that is anxiety-reducing, muscle relaxant and anticonvulsant effects. In clinical practice, midazolam has several legitimate and important uses. It is used for procedural sedation, for example before endoscopy or minor surgical procedures. It is used for the emergency treatment of seizures, and it is used in palliative care, in end-of-life care, to manage distressing symptoms such as agitation, breathlessness, and anxiety in patients who are dying. This last use is what we need to focus on today. Now, in palliative care, midazolam is typically administered via a syringe driver, which delivers a continuous subcutaneous infusion. This allows for steady symptom control without the need for repeated injections. It is part of what we call anticipatory prescribing, where medications are prescribed in advance so they are available when needed, particularly important when a patient is expected to deteriorate. This is standard, accepted, evidence-based palliative care practice. That is important context. So what happened in the early months of 2020? Well, let me show you the prescribing data. According to figures from the National Health Service Business Services Authority in England, there was a very substantial increase in community dispensing of midazolam in March and April of 2020. The data shows that in April 2020, community dispensing of midazolam was approximately double what it had been in the same month the previous year. Some analyses have suggested the increase was even higher when looking at specific formulations or routes of administration. Now, this spike in prescribing coincided with several things happening simultaneously. We had the rapid spread of a novel respiratory virus. We had the discharge of hospital patients, including to care homes, to free up hospital capacity. We had guidance issued about anticipatory prescribing for end-of-life care. We had restrictions on hospital visiting. And we had, tragically, a very large number of deaths occurring in a relatively short period of time, many of them in care homes and in the community rather than in hospitals. The question that has been raised is this: did the increased use of midazolam contribute to deaths, or was it simply a reflection of the increased number of people dying who required palliative care? This is where careful analysis becomes essential. Let me walk through the different pieces of evidence and explain what each one does and does not tell us. First, let us look at the temporal pattern. The spike in midazolam prescribing in March and April 2020 does correlate temporally with the spike in excess deaths during that period. However, and this is absolutely crucial, correlation is not causation. We cannot conclude from a temporal association alone that one thing caused the other. It is entirely possible, and indeed expected, that when more people are dying, more palliative medications will be prescribed because more people need symptom control at the end of life. Think about it this way. If I showed you data demonstrating that umbrella sales increased at the same time as rainfall, you would not conclude that umbrellas cause rain. The relationship would be the other way around, or both would be caused by the same underlying factor. Similarly, increased deaths could drive increased midazolam prescribing rather than the reverse. However, I want to be fair to those who have raised concerns. The argument that's been made is not simply about correlation. Some analysts have pointed to the magnitude of the increase, suggesting it was disproportionate to what would be expected from increased deaths alone. They have also pointed to the timing, noting that the peak in midazolam prescribing appeared to precede or coincide with the peak in deaths rather than follow it. And they have raised questions about the guidance that was issued and how it was implemented. Let us look at each of these points. On the magnitude question, this requires comparing the increase in midazolam prescribing to the increase in deaths. If deaths doubled and midazolam prescribing doubled, that would be proportionate. If midazolam prescribing increased much more than deaths, that would raise questions. The analyses I have seen suggest the relationship is complex and depends on how you measure each variable. Different analysts have reached different conclusions, and I think this reflects genuine uncertainty in the data rather than a clear answer. On the timing question, this is methodologically challenging because there are lags in data reporting, differences between when medications are prescribed versus dispensed versus administered, and regional variations in timing. When we are dealing with events happening over a period of weeks, distinguishing whether A preceded B or vice versa becomes difficult. On the guidance question, the National Institute for Health and Care Excellence did issue rapid guidance in April 2020 on managing symptoms, including respiratory symptoms, in patients with suspected or confirmed coronavirus disease at the end of life. This guidance included recommendations for the use of midazolam and morphine. The question is whether this guidance was appropriate and proportionate, and whether it was implemented correctly. Now, I want to discuss something called the principle of double effect because it is central to understanding palliative care ethics and this situation. In palliative medicine, it is accepted that medications given to relieve suffering may, as a secondary effect, hasten death. The classic example is morphine given for pain relief in a dying patient. The dose that controls pain may also suppress respiration. This is considered ethically acceptable under the principle of double effect, provided that the intention is to relieve suffering, not to cause death. The action itself is not inherently wrong. The good effect is not achieved through the bad effect, and there is proportionate reason for accepting the bad effect. This principle is recognized in law, in medical ethics, and in professional guidance in the United Kingdom and many other countries. It is the basis for palliative sedation, which is used when other measures have failed to control refractory symptoms at the end of life. However, and this is the crucial point, the principle of double effect requires appropriate indication, appropriate dosing, and appropriate intent. If medications are given without proper indication, in excessive doses, or with the primary intention of ending life rather than relieving symptoms, that would be a different matter entirely. That would not be palliative care, that would be something else. So the question is not whether midazolam was used, or even whether its use increased. The question is whether it was used appropriately, in appropriate doses, for appropriate indications, with appropriate monitoring and assessment. And here is where we encounter a significant limitation in the available data. The prescribing data tells us how much midazolam was dispensed. It does not tell us how it was used at the individual patient level. It does not tell us the doses administered. It does not tell us the clinical indications. It does not tell us whether there was appropriate assessment and monitoring. It does not tell us whether patients who received midazolam would have died anyway from their underlying condition, or whether the midazolam contributed to or hastened their deaths. To answer those questions, you would need detailed clinical records for each individual patient, reviewed by clinicians with expertise in palliative care. You would need post-mortem examinations. You would need comparison with what would have happened if different decisions had been made, which is of course impossible to know with certainty. Now, there have been some attempts to investigate specific cases. There have been inquests into individual deaths. There have been complaints to regulatory bodies. There have been investigations by journalists, and in some cases concerns have been substantiated about inadequate assessment, inappropriate prescribing, or failures of care. These individual cases are important and should be taken seriously, but extrapolating from individual cases to population-level conclusions is methodologically hazardous. The existence of some inappropriate prescribing does not mean that all prescribing was inappropriate, and the absence of proven harm in most cases does not mean that harm did not occur in any cases. We are dealing with large numbers and statistical distributions, and the truth is likely to be somewhere in the complex middle. Let me now address the question of what we know and what we do not know, because I think clarity on this is essential. What do we know? We know that midazolam prescribing in the community increased substantially in March and April 2020 in the United Kingdom. This is documented in dispensing data. We know that excess deaths increased substantially during the same period, with a significant proportion occurring in care homes and the community. We know that guidance was issued recommending anticipatory prescribing and symptom management for patients expected to die. We know that the pandemic created extraordinary pressures on the health and social care system with staff shortages, supply chain issues, restrictions on hospital visiting, and limited access to usual services. We know that palliative care is an appropriate and ethical response to dying, and that medications including midazolam are legitimately used for symptom control at end of life. What do we not know? We do not know, at a population level, whether midazolam use was proportionate to the clinical need. We do not know how many patients received midazolam appropriately versus inappropriately. We do not know how many deaths, if any, were hastened by midazolam use that would not have occurred or would have occurred later without it. We do not know the individual circumstances of thousands of deaths that occurred in care homes with limited documentation and oversight. We do not know, and may never know with certainty, the counterfactual, what would have happened if different policies had been followed. Now, some people have called for a full public inquiry specifically into midazolam use during the pandemic. Others have argued that the existing coronavirus inquiry will cover relevant issues. My view is that legitimate questions have been raised that deserve serious investigation, but that investigation needs to be conducted rigorously, with appropriate expertise, and without predetermined conclusions. Let me also address the question of plausibility. Is it biologically plausible that inappropriate midazolam use could cause or hasten death? Yes, it is. Midazolam is a central nervous system depressant. In excessive doses, or in combination with other depressants like opioids, it can cause respiratory depression, which can be fatal. This is pharmacology, not speculation. The question is not whether midazolam can be dangerous. The question is whether it was used dangerously in this specific context. Equally, is it plausible that the increased prescribing reflected appropriate palliative care for an increased number of dying patients? Yes, that is also plausible. When you have a surge in deaths from a respiratory illness causing breathlessness, anxiety, and distress, you would expect increased use of medications to manage those symptoms. That is what good care looks like. The honest answer is that both of these things can be true simultaneously. It is possible that some prescribing was appropriate and some was not. It is possible that the overall pattern reflected genuine clinical need while individual cases involved inappropriate practice. Reality is often messier than narratives that seek simple explanations. I want to make one more methodological point. When we are trying to understand events like this, we need to be careful about what statisticians call confounding variables. A confounding variable is something that is associated with both the exposure, in this case midazolam, and the outcome, in this case death, and can therefore create a spurious appearance of causation. In this context, the confounding variable is the underlying risk of death. Patients who received midazolam were, by definition, patients who were expected to die or who were experiencing severe symptoms. They were not a random sample of the population. They were a selected group with very high mortality risk. Comparing their outcomes to the general population would not tell us anything useful about the effect of midazolam. The appropriate comparison would be between similar patients who did and did not receive midazolam, and you would need to control for severity of illness, age, comorbidities, and other factors. That kind of analysis has not been done to my knowledge and would be very difficult to do retrospectively given the limitations of the available data. Now, I also want to acknowledge the human dimension of this discussion. We are talking about people who died. We are talking about their families, many of whom were not able to be present during their loved ones' final hours due to visiting restrictions. We are talking about healthcare workers who were working under extraordinary pressure, making difficult decisions with limited information and resources. Whatever conclusions we draw from the data, we should do so with humility and compassion. For families who have concerns about the care their loved ones received, I would say that those concerns deserve to be heard and investigated. If you believe that inappropriate care contributed to your family member death, you have the right to raise a complaint, to request an inquest if one was not held, and to seek answers. The pathway for doing this varies depending on the setting and circumstances, and organisations like the Care Quality Commission, the General Medical Council, or patient advocacy groups can provide guidance for healthcare professionals who provided palliative care during the pandemic. I would say that the use of Midazolam and other medications for symptom control at end of life is legitimate, ethical, and often the kindest thing we can do for dying patients. The scrutiny that has followed should not make clinicians reluctant to provide appropriate palliative care, but it is also a reminder of the importance of documentation, assessment, and working within guidance. Let me now briefly discuss what we can learn from this situation going forward. First, there is a need for better data. The fact that we cannot answer basic questions about whether prescribing was proportionate to need reflects limitations in our data systems. Better linking of prescribing data with clinical data and outcome data would allow for more meaningful analysis. Second, there is a need for clear, consistent guidance that is appropriately communicated and implemented. Rapid guidance issued during a crisis may not be interpreted or applied consistently, especially by staff who may not have specialised training in palliative care. Third, there is a need for oversight mechanisms that can identify potential problems in real time, not just retrospectively. If there were concerning patterns of prescribing, those should have been detected and addressed at the time. Fourth, there is a need for honest public communication about uncertainty. It is tempting to provide simple answers to complex questions, but doing so can erode trust when the simple answers turn out to be incomplete or wrong. Acknowledging what we do not know is not a sign of weakness. It is a sign of intellectual honesty. So where does this leave us? The truth is we are left with more questions than answers. The data shows an increase in Midazolam prescribing that coincided with a period of high mortality. The data does not tell us whether that prescribing was appropriate, proportionate, or causally related to outcomes. The existing analyses point in different directions depending on assumptions and methods used. Individual cases of concern do not prove systemic problems, but nor do they rule them out. I think reasonable people can look at this evidence and reach different conclusions. Some will see the prescribing increase as a proportionate response to a surge in palliative care needs. Others will see concerning patterns that warrant further investigation. I do not think either position is unreasonable, given the limitations of the evidence. What I do think is unreasonable is certainty in either direction. Anyone who tells you they know exactly what happened, that they can prove Midazolam killed thousands of people, or prove that it did not, is claiming knowledge they do not have. The honest position is one of uncertainty and continued inquiry. So what should you take away from this discussion? I would say the following. First, learn to read health data critically. Ask questions about correlation versus causation, about confounding, about what the data does and does not show. This skill is valuable well beyond this specific topic. Second, if you have specific concerns about care that a family member received, pursue those through appropriate channels. Do not assume your concerns are invalid, but also do not assume they will be confirmed. Seek the facts. Third, recognize that good palliative care involves difficult decisions about symptom control in dying patients. Medications that provide relief can also carry risks. This is inherent to end-of-life care, not evidence of wrongdoing. Fourth, be wary of narratives that are too simple, whether they claim that nothing wrong happened or that there was a deliberate policy to end lives. The reality is almost certainly more complex than either narrative allows. I want to close by saying that the questions that have been raised about this topic are legitimate. People deserve answers about what happened to their loved ones. The system should be able to account for its actions and learn from its mistakes. At the same time, the investigation of these questions should be rigorous, fair, and evidence-based, not driven by predetermined conclusions or political agendas. This video is for educational and informational purposes only. It is not medical advice. If you have symptoms or concerns, please consult a qualified healthcare professional. We use publicly available data and reputable sources, and interpretations may evolve as new evidence emerges. I would also encourage you to look at the primary sources yourself. The prescribing data is available through the National Health Service Business Services Authority. The guidance documents are published by the National Institute for Health and Care Excellence. The mortality data is available from the Office for National Statistics. Do not take my word for it or anyone else's word for it. Look at the data, think about what it shows and what it does not show. That is the essence of being an informed citizen in matters of public health. Thank you for watching. I appreciate your time and attention on this difficult topic. Take care.